Welcome to this episode of the Medical Fitness Podcast. My name is Thomas Hammett, and I'm the Director of Operations for Pinnacle Lifestyle Medicine. As we dive into today's episode, I'd like you to consider this question. Does exercise prescription really matter, or is the simple message to move more enough? For decades, public health campaigns have encouraged people to be more active, and for good reason. Any movement is often better than none. But when we're talking about preventing disease, managing chronic conditions, and reducing pain, improving function, or helping people achieve meaningful health outcomes, is movement alone sufficient? Or does the specific prescription, the mode, intensity, frequency, progression, and support strategy actually make the difference? In this episode of the Medical Fitness Podcast, we're exploring the tension between moving more and exercise as medicine. We'll discuss where general physical activity advice is valuable, where it falls short, and whether effective exercise programming is more art, science, or both. We'll also tackle the growing number of condition-specific exercise recommendations, examine what really should change across diagnoses like diabetes, hypertension, arthritis, cancer survivorship, and low back pain, and identify the foundational principles that do remain consistent. Finally, we'll address a question that affects patients, clinicians, and fitness professionals alike. How do we separate evidence-based exercise prescription from the endless stream of vague advice, social media trends, and what some might call exercise voodoo? Joining me today to help unpack these questions is Jeff Young, founder and CEO of the Medicine Rehab and Fitness Institute, and David Flench, CEO of the Medical Fitness Association. Welcome, guys.
Hey guys,
Hey,
good to
Thomas.
see you again.
Jeff, how are you?
Doing well.
All right.
So to start our conversation, guys, the first question we have to answer is this. When is just move more an appropriate message? And when is it too vague or insufficient?
I'll jump in because I have a few thoughts on this, but I know Jeff has quite a bit. So,
I'm going to hog the whole podcast.
I think move more can be appropriate, especially when somebody's inactive, early in their readiness for change, or maybe if they need a low barrier starting point to build some confidence. I early in my career, I picked up on a research study that I used pretty often in various presentations. I'm sure you guys are familiar with Dr. Stephen Blair's 1989 work that talked about going from the lowest level of aerobic fitness to the second lowest level can cut mortality rates in half or more. So really at a population level, I think helping more people become less sedentary is still one of the most important opportunities we have. But that being said, I think it becomes insufficient when there's a specific health condition, pain, deconditioning, treatment, history, defined outcomes that are needed, where safety and exercise dosage, progression, and monitoring, all those things need more structure. So I think it's not that one is bad and one is good. I think moving more is appropriate in certain conditions, but really it becomes too vague in others.
I agree. With some people, it's the start point. And just like you said, it depends on where they are as far as their stage of readiness. And for some people, that's just where you need to start. But what I am bothered by with this argument and this friction between move more and exercise is that the pendulum tends to swing too far, either towards one or the other. It's a continuum. As you just mentioned at the end of what you said, is that they're both good. So it's not like one's better or one's bad and one's good or something like that. It lies on a continuum. But I do want to mention something about you have to remind me the way you word it, because it's something I see pretty often, like on my social media platforms, where it's the first X amount of exercise or movement that you do, it makes the biggest difference in your health. So it was something to that effect.
Jeff, you're talking about the research study I just referenced.
Yes.
It
Yes.
was it was looking at aerobic fitness levels. So going from, the very lowest to the next lowest category. So meaning that you're just incorporating a small amount of aerobic exercise, and your fitness level has improved to that level. They were finding mortality rates cut in half.
Right. So you get the biggest gains early on is basically what the message is with that. And I'll be honest, what I don't love about, I get it, and it's not like I can disagree with it, but what I don't like about it is it corresponds with the principle of initial values, which basically says the same thing. The larger your window of improvement, or in other words, the lower your fitness, the greater your gains early on. So it follows a principle, but I think that what we're missing with that with that message is that fitness lies on a continuum from, and there's all kinds of different ways you can word the continuum, but to get my point across, you can go from very, very low fitness to low fitness, and you significantly move forward, and so it had a significant improvement in your health, but you're still low fitness. And so I think that what we need to do is look at both simultaneously. Yes, moving more is going to, especially early on, is going to have a significant improvement in health and mental health and all kinds of great things. But we still also need to look at what's your fitness level objectively and have that as a point of reference as well. And I think that's where exercise comes in. I think that's why moving more can be a great start point for a lot of people. But we can't forget about the importance of structured progressive exercise, because that's where fitness comes in. And we need to focus on fitness as well. So I'll stop there, but that's my general view on that.
Yeah, Jeff, I'm pretty aligned with what you're saying. And I think part of the nuance to this question of when is just move more an appropriate message, I think move more is a strategy underneath a bigger goal, right? And I think what I'll do here is make a parallel to like to financial analogies. And David and I have talked a little bit about this because I think the growth of health and the growth of wealth have very similar principles, right? So if you want to retire someday, and you want to retire someday, and your financial advisor just says, "We'll save something," like start saving something, and doesn't give you specific strategies, and doesn't tell you how much to save, or for how long, or how much more you should be saving over time. It's kind of a guess as to whether you're going to retire, right? And what that retirement might look like. To be successful at getting to that place where at a later age you're going to have the kind of retirement that you've dreamed of. And a lot of people haven't necessarily dreamed of retirement, so let's take a moment and try to picture what that might look like, and then make goals based on that. This conversation has to start with, what do you want your health to look like as you age? And then let's make recommendations based on that. And I think most people, like, it's not wild to say most people want to live long lives at the age when they're ready to retire. They don't want to be dealing with chronic disease and disability. So should we make haphazard recommendations of just move more and that's kind of it? And I think, again, if the question is when is move more an appropriate message, I think we have to think about who's making these recommendations. And I always take the lens of, I'm someone's healthcare provider, and I am helping them think about living into a longer, healthier life and meet these goals that they have, not just short term, I want to get out of pain, or deal with this condition and make it just like go away for a little bit, but help these people live longer, healthier lives. That means I have to be specific enough that they know where they're going. And the first recommendation might be, okay, you need to start moving more. But hopefully we can be a little bit more specific than that. If we're going from nothing at all, and that's the start place, maybe it is, let's walk a little bit each day. Like that would be a move more type recommendation that we could at least make specific enough that they know what they're doing. But I think if we're being honest with ourselves, the physical activity guidelines exist for a reason, right? Meeting your 150 minutes of moderate intensity exercise plus resistance training for your entire body 2 to 3 times a week. Those don't exist for no arbitrary reason. Like, if most people are doing that amount of movement, this is the retirement plan. Like, that's the specific retirement goal people should have as their anchor. That doesn't mean that that's what you're doing right away. That would be an insane recommendation for someone who's starting at zero. But if we don't at least say that people should get there and help them figure out how they're going to take small steps there, just saying walk, take the stairs more or park further away when you go to the grocery store is just not, it's not helping people with their retirement plan for their health. And I think that to me is the difference. Make move more part of a strategy to help people get to a place where they're exercising in a healthy way. And I think we've just given up on getting people there because we don't have good infrastructure to support people getting there. And that's probably the bigger issue here.
Thomas, one of the things that I'll just highlight that I love what you're saying, and before I say this, I remember what you were talking about with the whole financial analysis and retirement, because you wrote a great article on that. I think it was in one of your newsletters, and it really helps frame it for people in another light that's so similar. But you said, what their goals are in retirement. I think that's such an important thing that it seems like that aspect sometimes is being skipped, where we're going straight into here's what you should do without even understanding of where they want to go. And so I think that's kind of a critical piece of what you're saying, and it kind of leads into the next topic that we were wanting to discuss in terms of what makes exercise prescription different from just general physical activity advice. And I've got just a couple of comments on that, and then I'd love to hear what you guys are want to say about that. But to me, an exercise prescription really should be very intentional, should be individualized. We all talk about the FIT principle, so frequency, intensity, time, type. Concepts like progression, overload. I know those are some of Jeff's favorite things to talk about. But several things go into an exercise prescription. I think it really it needs to start with the person, their goals, not necessarily their condition. That absolutely plays a factor in there. But where we start is what the person is ready to do and the goals that they have going forward, not just what is ideally on paper for a particular diagnosis. So I had a LinkedIn post recently around this subject, and someone left a pretty good comment that I felt really reinforced some of this. Is they were saying most people don't necessarily want more choices. They want somebody who's credible and expert to help them know where to start and how to progress over time. And the point was basically too many options can actually become a barrier. And having, some multifaceted exercise prescription, very complex right off the bat, especially for somebody who's sedentary or just new to exercise, can be a real big barrier for them. So I think, exercise prescription has its place, but starting with where the person is, meeting a person where they are, that's, it's something that we have to keep in mind.
I couldn't agree more. Thomas, let me just start by saying that you really nailed it. Like, you nailed it on so many different levels, and it was just a really great way to start the discussion. Couldn't agree more with everything you said. And then with David, yes, also can't agree any more with everything you said. My mantra when it comes to programming, whether it's a patient, client, or athlete, is you screen, assess, initiate, progress. That's the algorithm, and that's really what you were getting at. You can't, we shouldn't be just initiating without first screening and assessing. And you screen and assess everything, not just their physical capacity and movement capacity and stuff like that, but also where are they at mentally, what's their exercise history, all the things that fitness professionals should be performing in the initial consultation. It's obviously why ideally you would start with a consultation and just the park queue and let them tell their story, and go from there, and then take their story into consideration when you're designing the program as one of the ways to individualize it. But yeah, I couldn't agree more with what both of you said.
Yeah, David, the question that you kind of were starting from after your last point was what makes exercise prescription different from general physical activity. I mean, the primary thing is that it's intentional and planned, right? Like, again, if we're going to go back to the financial analogy, uh, you may this month have more money in your bank account than last month. And that could be by total accident. It could be a complete accident that you happen to spend less than you made last month. Does that mean that you were saving on purpose and that that's a sustainable plan that helps you meet a goal? Not necessarily. And I think you can be and moving in a way that even could be considered exercise, of course, that gives you health benefit, but without any plan or regularity, that is not something that is going to accumulate the kind of gains that give you health over time, right? Exercise, just inherently by being planned and intentional, gives you a shot to build off of what you've been doing consistently. It's the same from a financial standpoint. The variables of intensity and volume and progression, adherence to strategy are all things that help you know whether you are doing something that's planned and intentional or not. And again, I think where people go crazy with this is you think that exercise is only exercise if you're meeting the physical activity guidelines, right? If you're in a gym lifting weights, or if you're wearing a certain kind of outfit, and that's not what this is. As much as I don't hate. It has taken me a long time to warm to the idea of exercise snacks, because I think by themselves they are underwhelming. But if it's part of a strategy to get people to a place where they're going to grow from that, great. It is intentional. It has a planned element to it. It has a name that shows that people are thinking about it and doing it. Great. As long as it's part of a greater plan that helps you move from that to a place where you know that you're getting the kind of physical activity and exercise that prepares you to meet the demands of your daily life and to improve your health. And it's as simple as those two distinctions for me.
Thomas, I'd like to respond to the exercise snacks because I don't know that you and I have ever talked about that, but I'm right there with you on that. And I think that kind of falls a little bit more into the move more category, and a good place to start with people. But I think that it's missing the point. And for me, the ultimate goal should be some level of fitness, objective fitness, and so that you're not preferably not average, and definitely not below average in fitness. And exercise snacks are a good place to start, but they're likely not going to improve your fitness enough that your strength and aerobic capacity are above average. And unless you have unbelievable genetics or something like that. And so I couldn't agree more with that. And also, when I think about the fit VP principle, related to what you said, it's just another way to word it is dosing. And I'm kind of going to jump off to the side for a second and hopefully come back to it. But Dr. Bill Kramer, who we've had on this podcast before, and he's my mentor, and um, uh, just amazing sports scientist and strength and conditioning researcher. And I live stream him into to guest lecture for my students in the fall, my strength and conditioning students. And one of the things he'll say related to what we're talking about right now is have a plan, which is exactly what you're talking about. Have a plan, log the plan, which is just missing, like especially in the health club world. So many people are not logging their plan. And if you aren't logging, as a matter of fact, he'll say, if you aren't logging your plan, you don't have much of a plan. And I couldn't agree with that more. You have to keep logs because that's going to help you track. And then when you're tracking, that's when the progression can come in. So going back to the Fit VP principle, it's a way to dose. It's a way to dose your program. And then if you're truly tracking it, then now you can start to see your progression. And as you see your progression, then you get motivated. and it actually will increase adherence and all the good things that go along with it. But so many people are just either moving more or just randomly exercising, and they're going in and they're getting a good sweat and all that stuff. But there's no intent. There's no intentional plan, long-term goal. Um, like really thinking about how to manipulate the frequency and the intensity and the volume and things like that as a way to optimize it. And there's really a lack of tracking and keeping training logs going on, especially when it comes to it. Well, probably both aerobic and strength training, but in the world I live in, strength training, people are just not keeping logs. And so those are the things that came to mind when you were talking.
Yeah.
Real quick, you guys, on the exercise snacks and some of what you were just saying, Jeff. I can see it from so many different angles. Something that I think of when I think of this exercise snacks is a concept that Dr. Andrew Mock has put in front of me and some of his presentations is no zero days. So, it's kind of like when
Yes.
life gets in the way, just at least don't have a 0 day, meaning where you don't do any activity, exercise, whatever at all. You find some way to take 60 seconds and do something, or 5 minutes and do something where it's not going to be as great as our ideal exercise prescription followed to a T, but kind of keeps you in the game, keeps you moving forward, and keeps you from having what sometimes could fall into several days, weeks of inactivity when life just gets hectic. So, having a strategy, I think that's where some of those things come into this, where, understanding that, we're meeting somebody where they are, they're going to have some life issues, and that, you may progress for a while and then you may fall off, and we might have to reassess. We might have to, rescreen you depending on how long it's been, and get you back to that. But having some of these strategies in place, I think that's where some of that concept is pretty helpful.
Yeah, the no zero days to me is a really effective mindset, and what I would call both a mindset overall, but also a good plan B if plan A doesn't work out, right? So because what I hear when I hear no zero days is like, I didn't get to go do whatever I had in mind for the day, so maybe I do some air squats at home or some push-ups and crunches, right? Not plan A, but I'm going to do something. Maybe I'm going to take a walk around the neighborhood, whatever that is. Assuming that there is a plan A and that you're using that philosophy to guide how every day you should be active, I love it. I love it so much. If no zero days is for the person who has no plan A and it's just like, I'm going to randomly do some push-ups and some sit-ups and whatever. To Jeff's point earlier, that may help you with early on. You may see some outcome from that, but there's not much you're going to get from that after doing that for a couple of weeks. And I think a lot of people get frustrated feeling like, well, my new routine of push-ups and sit-ups and walking around the neighborhood really hasn't changed my health. Exercise doesn't work, right? So I love the no zero days for people that have some kind of plan A. And, again, that plan A can be for people who are just getting started. It's if I'm a medical provider, I would rather recommend a plan A of walk 2 minutes a day and log it than park further away and take the stairs,
Yes.
because the outcome may be the same. It's just one has a plan that you're setting up to build off of, and one does not.
Yep.
And it leads to, hopefully it happens. Maybe I go to the grocery store that day, or wherever it is that I have stairs that I can take. And I think that's just generally my summary on both the no zero days, which again is a great rule, assuming there's a plan A, and let's make sure that plan A has some kind of plan to it, to Jeff's point.
Just awesome stuff.
So maybe we can move now into the condition-specific training versus universal programming principles. How do you guys think, how much should programming differ between conditions, and where do these core principles remain the same?
Well, I guess I should go ahead and start with this one. The first thing I'm going to do is actually plug uh, an article that was just published in the American Journal of Lifestyle Medicine that Dr. Andrew Mock and I co-authored, and it just came out days ago. It's titled Resistance Training for Special Populations, a universal, clinically safe, scalable framework for progressive training. Um, Going back to what I said earlier, what I've learned across my career working at hospital systems, Duke, UCLA, Beth Israel, Mount Sinai, and across the spectrum of cardiovascular, metabolic, neurological, pulmonary disease, is that what matters the most, and I'm beating a dead horse, is increasing your fitness. And that, the common theme, and I know I'm simplifying it here a little bit, maybe even a little bit too much, but the common theme was that nearly everyone who was referred to our medical fitness programs were deconditioned. They were, whether it's politically incorrect or not, they were weak and deconditioned. And just by improving their fitness and doing it in a way that we're talking about right now, where it was intentional, where it was planned, where you were logging it, where you were actually keeping in mind what the objective points of reference were, and not just the fact that, oh, good, person is moving forward, because they may be moving forward again from very, very deconditioned to deconditioned. Hey, they move forward and saw significant improvement, and that's great. But you still have to keep in mind objectively, where do they lie as it relates to population norms, and what the norms should be for their biological sex, for the decade of life that they currently live in, et cetera. So we always kept that in mind. And so with that as a backdrop, just by getting more fit, and I'm going to even define fitness a little bit more. I think the exercise and fitness can be a little ambiguous, so I'm going to dive a little deeper into that. I mean by improving your strength, conditioning, power, and lean muscle tissue. The four primary ways that the body responds physiologically to exercise training. So when you have those things in mind and you're designing a program that addresses those things, then just by the very nature of getting more fit, you, hopefully some of our listeners are familiar with myokines and exerkines. And so basically the fact that muscles are an endocrine system, and so all of a sudden there's all this crosstalk going on. And again, simplifying it, probably a little bit too much, but to get my point across, what's happening inside the body is we're intentionally exercising and improving our fitness, is that our muscles are saying to the other systems and organs in our bodies, we're working here and we need your support. We need you, cardiovascular system, pulmonary system, neurological system, to get better at what you do. And so that as you improve your fitness, then in the long term, what's happening is you're improving the health and function of each system in your body, and therefore addressing neurological conditions, pulmonary conditions, cardiovascular conditions, etc. So with that in mind, yeah, you screen, you assess, you initiate by meeting the person where they're at, and then you intentionally progress by putting the person on a structured program. And then from there, you just you set up a framework so that and the framework is the Fit VP principle, basically. So there's your framework. Now there's your dosing. And then within that framework, you modify accordingly. And so if the person has a neurological condition, you've heard me say this a million times before, but my wife with multiple sclerosis, I wouldn't train her any different than I would anyone else. Screen, assess, initiate, progress. Use the Fit VP principle and periodization as the framework, but she has multiple sclerosis. So because of that, she can't get overheated. That's her kryptonite. So it's a cool environment. It's making sure she's hydrated, etc. But using that as an example, you just need to know what your precautions are, what to be cautious about with different conditions, and you just need to know what conditions are. And that's where the good coaching comes in. And I could go on, but that's the my view. It's confusing and unnecessary to do to say we need disease or condition specific programming. Instead, learn your framework and learn how to modify within it.
I want to make just a quick because I think the medical provider on you listening to us right now is going to be thinking the thing that I'm going to say, and I want to say it, and then I want to take the caveat of what I'm about to say as well. So the medical professional listening might be thinking, and I'm a physical therapist, so I'm thinking about low back pain in particular, David, or the conditions that you listed off. The early phase prescription for someone with acute low back pain might look way different than the kind of exercise that Jeff is talking about. And maybe for good reason during the acute phase of injury. But it's not very long. I mean, we're talking about maybe a couple weeks that we just need to do movement, whatever it is, pain relieving type exercise that probably otherwise makes no real benefit to that person's overall fitness, so that they can get to a place of getting out of acute pain and then start doing the things that Jeff's talking about. And the problem in medicine is that we view everyone as if they're in the state of acute low back pain. We view everyone as if they've just had a car accident. Even, by the way, people who are dealing with cardiac conditions that are a product of a life of likely being sedentary and making suboptimal nutrition and other lifestyle choices. So we treat them as if they're in an acute situation that wasn't a product of not being moving before that, right? And we have to stop, from the medical standpoint, viewing people as if they're always in that acute phase of injury or acute phase of, a high blood pressure. Outside of very few situations for people with high blood pressure, which just pretty much requires monitoring, we're doing the exercise Jeff's talking about. And we have to stop viewing people like that from the medical context. If someone needs to do prone press ups or cat camel stretching and yoga in the early phase of low back pain, fine, but they should not be doing that for 6 to 12 weeks. If they're doing that for 6 to 12 weeks, what you're doing is ineffective, and you should have moved on long ago to the familiarization phase of a full body resistance training and cardio program.
If you're a clinician looking for a safe, trusted, and practical way to extend your care beyond the patient visit, the Medicine Rehab Fitness Institute can help. We provide virtual medical fitness services delivered by world-class coaches with graduate degrees, advanced training, clinical experience, and a clear understanding of chronic disease, musculoskeletal conditions, and post-rehabilitation programming. Think of us as the medical fitness extension of your practice. You screen, assess, prescribe, and refer to the trusted resource you've been looking for. We help support the patient with structured exercise programming, behavior change informed coaching, and communication back to the referring clinician. To learn how the MRF Institute can support your patients, visit mrfinstitute.org or reach out to me directly. Yeah, Thomas, again, you're just nailing it, and that's also something I'm just going to say what you just said very briefly and just word a little bit differently. The human body is not static. It's very adaptive, and you're exactly right. In the medical and in medicine, rehab, and even in the fitness world, we act like people are just stuck where they're at, and then what happens is they become their condition. And they become their low back pain, they become their multiple sclerosis, they become whatever their condition is, and we aren't helping them at all. And you're exactly right. As we improve fitness and flexibility and aerobic fitness, strength, flexibility, things like that, then the body's going to adapt and it's going to get better. And so we need to stop with acting like people are just whatever they've been diagnosed with, whatever their condition is, that's where they're at now forever. Absolutely not. We need to put them on a properly designed progressive program, improve their fitness, and watch them get better and watch their condition maybe not necessarily heal, but definitely be managed, controlled, reversed, and in some cases healed.
Yeah, I love what you guys are saying. The whole idea of somebody not starting somebody too complicated, I think is part of this. But that doesn't mean that they can't adhere to the core principles of an exercise program. Starting, like you said, Thomas, a provider who refers somebody for exercise, it really shouldn't be saying you can't do X, Y, and Z, maybe because of hypertension, like you mentioned. That's we know more about it. You just have to find the right exercises, right? Somebody with bad knee, whatever the issue might be, we might not be putting them on an open chain, leg extension, right? Yeah, certain things don't work as well for certain conditions, but we can always modify. And that's where, having somebody who knows what they're doing, who is properly trained is important. It kind of reminds me earlier, I think Jeff might have mentioned that the PAR-Q, physical activity readiness questionnaire as a screening tool, which is good, but it's been improved upon even,
Yeah.
because we even found that was something that was limiting people from starting exercise. And so I think it was maybe about 10 years ago when ACSM came out with their own newer version of I call it the PAS-Q, a physical activity screening questionnaire that doesn't push people out from starting their exercise program, and allows people to do something. And when they do something, then building upon that. And again, I mean, I think people might be getting sick of the word progression here, but I mean, it is a big part of what we're talking about, starting at whatever point that person needs based on their fitness level, their condition, etc. But again, I don't think the condition requires any different set of principles and a different universe of exercise. It's just not. I think we can all agree that the principles remain the same. It's how you apply them.
Without a doubt. Go ahead, Thomas.
Yeah, well, I just think it'd be really helpful for the listener guys if we could give some examples of what it looks like when it goes wrong, right? What are the bad examples of condition specific recommendations that may appear from the outside to be medical, but are just not both not medical, not following these guidelines, the things that you see that make you go, uh-oh. Do you guys
Yeah.
have some examples you could share?
I'll jump in real quick here, and I was talking to a colleague not too long ago, and one of their loved ones was in cancer treatment, and their doctor told them not to exercise at all, to avoid exercises, specifically strength training. And we know that there are so many benefits to both the treatment phase, recovery, survivorship. So a condition like that, where a physician, they specialize in what they do, and I'm sure this doctor was great at the cancer treatment phase, but not knowing, it's not always something where all of our clinicians know everything that we know about the benefits of exercise and how to apply it and things like that. So I was kind of shocked to hear that, just knowing how far the research has come and things like that. But I think that's something that I think is probably more prevalent than we want it to be, where particular conditions, I can think of, pregnancy used to be this thing where, oh, you want to really back off. Yeah, you don't want to start something brand new, and intense. But if you've been, active before, there's no reason to not continue it. So a lot of these conditions where it's just overly cautious advice and recommendations, I think can really underdose. Like Jeff was saying, it's the dosing. We tend to underdose, and that just limits the progress that somebody can make. And so I think, again, if we're applying this generic advice, we can really miss out on allowing somebody to make improvements in ways that they really can.
Yeah. My example will be musculoskeletal. And I'm actually going to go to low back pain. And for example, deadlifts. And deadlifts they're going to kill your back and stuff like that. During my time at Mount Sinai, I collaborated with a physiatrist, MD, who was at Mount Sinai Spine Institute, and he would refer patients with, anything you could think of, whether it was one of the spondies or stenosis or herniated discs, etc. And he was a strength athlete, so he competed in Olympic lifting. So he was all about progression and getting people strong and stuff like that. And using this as an example, what the protocol that we was you wouldn't start by someone doing deadlifts by pulling from the instead you pulls where you just, in other words, you shorten the range of motion where the bar actually started above their knees. So you got them over to the racks where the bar was, in other words, they were barely moving at all. And you would just, going back to the fit VP principle, if you just reduce everything, frequency, let's say you do deadlifts just once a month, for example, you just to use an extreme example, you only do deadlifts once a month. The intensity is just a warm up set. The volume is just one set per month. And you're you're finding the person's pain-free range of motion, and you're making sure you're staying within it by significantly reducing the range of motion. Now all of a sudden deadlifts aren't unsafe. And then what you do is you just progress over the course of time in small tolerable increments by manipulating those variables. And that's where the art would come in. What are you going to manipulate first? Are you going to maybe go to twice a month? Are you going to go to a 5 RPE instead of a 4, whatever the case may be. But yeah, it's just, there's so many examples out there, and that's just one where don't do such and such exercise. It's going to kill your back, or whatever the case may be. When no, all we need to do is understand how to modify those things. Everything is modifiable. You can make it safe, and then you can progress from there.
My first instinct is to answer related to cardiac conditions. We manage a cardiac rehab program and support another cardiac rehab program across the mountains here in Washington. And the recommendations that cardiologists make around limitations for exercise for that population, 50-pound lifetime weight restriction for lifting,
Yes.
and amongst other things. That are largely, and it used to be no resistance training at all for those people in the acute phase of rehab. It was all in an effort to avoid what's called Valsalva, which is just hold your breath and increase, bodily pressure, because it could cause harm to your heart, right? Or the condition that was dealt with, whether it's an aneurysm or something else, right? So that is one to me that's just, we're making precautions that shouldn't exist in that specific of a way. Where my mind actually goes right now, I feel like one of the biggest areas of where this is happening is women's health, and particularly around menopause. That there's a lot of recommendations that people are giving globally, and this is medical and non-medical, right? Social media, influencers, people trying to sell things. And what I see a lot of, whether it's just blanket recommendations for programs like Pilates or bar, that what women in this particular phase of life need is to maintain bone and muscle strength. And what we give them is low intensity, high rep, low weight kind of work. And that's not a really great way to build muscle and bone strength. So it kills me when I see the blanket recommendation for women going through menopause, do Pilates, and that's your only exercise you need to do, right? Pilates and walk. Well, you're never loading yourself enough to maintain that bone strength that you want to maintain. That is the thing that you're most concerned about, that you're going back to get DEXA scans every few years for. So while it's a great form of exercise sometimes, it shouldn't be the way that you're going to single-handedly prevent the progression of bone loss and muscle loss that is just expected to happen at that phase of life.
Yeah. Well said. Couldn't agree more. In the time we have left, we're going to move on to a different topic, and we'll have time for one more question. But we've been talking a lot, or mostly in this episode, about the gap between medical advice, claims in the fitness industry, competent exercise prescription, etc. My final question for today's episode is: what should clinicians, patients, and fitness professionals look for to determine whether an exercise program is credible, appropriately dosed, like we've been talking about, and likely to improve health outcomes? And I think that might be a good way to wrap this up.
Well, I can start on that. In terms of what clinicians should look for, I strongly believe that the referral destination matters. It's not just whether they're telling somebody to exercise, which probably is step one of getting our clinicians to recommend it. But I think they're getting better at that. So uh, whether there is a credible standards-based environment behind the program with qualified staff, screening protocols, progression, built-in communication pathways, emergency preparedness, proper quality controls. Really, that's, from my MFA lens, where our standards, our facility certification, some of our other work can really show that what is happening in a program, in a facility, is not just well intentioned, but it's structured and credible, and it's ultimately one that physicians and other healthcare providers can trust what they're referring into.
I think my answer to this is pretty simple, and obviously our bias shows through here towards the end of this episode, because this episode is talking about, does prescription matter, and should we just move more, or should there be some kind of prescription? And the last thing that we're talking about is what kind of program or person would be a reliable and credible source. Clearly, we believe that it's not just moving more without a plan, that there should be some kind of plan. And in the best case scenario, that means having a resource that can support people. Because, Jeff, when you were talking about logs, maintaining logs is not something that a lot of people are successful with without support to start with, right? Like, to have someone to support you with doing that kind of thing, to have technology that can support you with doing that kind of thing, is, it deals with a lot of the barriers that people deal with trying to do this on their own. So yes, my bias is move more isn't a good plan without some kind of strategy behind it. Eventually, when people are ready and at that place, they should be consulting with someone who can support them to get the health optimization that's possible out of movement. And if you're a clinician looking for, what makes that place or person credible, just ask them, ask the fitness professional, ask the program director, what are you going to do with my patients? And if their answer is, well, it depends on the person. Okay, well, that's not a plan. I wouldn't necessarily trust a answer that is, it depends on the person. If it is, we do the same thing with everyone and it's specific and doesn't mirror what Jeff has talked about with best practice guidelines, well, that's not a good sign either, right? So, look for, there is a plan. There's a plan that mirrors what our certifying bodies say we should be doing for exercise. And that's probably a good place to stop, and then see what the outcome is. If they're tracking outcomes, what's your outcome? That would be an above and beyond answer that, the really good groups can answer and would be like a gold star.
And my response, this is also a topic that I could talk about for a long time, but my response is that there needs to be exercise literacy just across the board, because, you mentioned best practice guidelines. I wish every single person on this planet knew what they were, because if you don't know what they were, then all of a sudden anyone can say anything. You need that objective point of reference. If you don't have an objective point of reference, then one person can say this, and the next person can say that, and you don't have any idea who's right. So we need to, I wish everyone understood what best practice guidelines were, where to go to find them, which I'm going to put a plug in for the MRF Institute here in a second. But just knowing and just talking very briefly about, like, strength training, for example, best practice guidelines. I'm just going to mention a few things here. Everyone, no matter who you are, once you're on following the physical activity guidelines for strength training, needs to strengthen every major muscle group in your body. So there's a best practice guideline: legs, back, chest, shoulders, trunk at a very minimum. We need to have, the dosing needs to be enough to move fitness forward. So those are also references to best practice guidelines. If you're only doing 1 or 2 sets per muscle group per week, that might be a good place to start, but it's not a good place to stay. And so then the dosing's too small. And then even with like the intensity, if you're always just choosing weights that when you ended the set, you could have still done 4, 5, 6 more repetitions, the dosing's too small. You need to move forward, even in your later years, 60, 70, 80 years old. The weight that you're choosing needs to be such that it's taking you to at or near muscle failure. And I can go on, but I think that the best practice guidelines is something that, and therefore exercise literacy is something that everybody should be aware of. And since we're talking about your health, well-being, longevity, and quality of life, it's worth people, learning these things. And then that leads to the last thing I'll say, which is a plug for the Medicine Rehab Fitness Institute. We offer those things. We offer those things in the form of, I've been creating apps, to help people track, whether it's nutrition, but in this case, we're talking about exercise, to help make logging very simple. So check out the apps, resources that we have, and also the course that I have, Fundamentals of Medical Fitness. But these are at least places to start. And then not that the MRF Institute is the only place on earth with resources, educational resources, but I think that since we're talking about this stuff, may as well talk about the MFA, MRF Institute as resources for exercise literacy. And then you have some objective points of reference. Then you won't get duped when someone gives advice that you can just do this or just do that.
It's great. Thanks, Jeff.
One thing real quick, I wanted to try to add onto Thomas's concept of financial, the analogy. And so as it relates to this question of credibility, not everybody is going to need a person to guide them through exercise. Kind of like if I have the most basic financial picture in the world, I have one job that is very simple, and that's how I get paid, and I can maybe do my taxes on my own without an accountant. But as my financial picture gets really complex, I'm going to need an accountant to help me with preparing my taxes. As things get even more complex, I might have to find somebody that specializes in something. Um, you know, uh, I'm not going to go too far on the financial side because I don't know that world that well. But this is where having somebody credible to go to who knows what they're talking about. Thomas, like you said, they can't just give these vague responses when the communication is happening between trainer and clinician. There has to be some level of understanding of needing the plan and having the credibility in terms of the training, knowledge base, experience, that sort of thing. So I think the credibility is becomes even more and more important as the complexity of the people that we're dealing with becomes part of this conversation. So I do think that, like I said, having a place to go to where you do have the qualified staff and the structure set up is part of how physicians and other clinicians can know where they're sending somebody is going to produce the outcomes that they're looking for.
Yep.
Yeah. And, David, I don't think it's a wild concept for us to aspire to living in a world where people have retirement plans that involve having some money and having some health when they get to that age, and not dealing with so much disease or feeling stuck without the ability to stop working. So really good analogy, and I appreciate you putting a cap on that. Well, this is a good time to wrap up our episode this week of the Medical Fitness Podcast. If you have thoughts on this topic or suggestions for future topics, reach out to us on LinkedIn. And we look forward to seeing you guys next time on our July episode. So take care.
Great talk, guys.
Thanks, guys.
The Medical Fitness Podcast is brought to you in part by the Medical Fitness Association. Exercise is powerful, but where people are referred matters. For individuals with chronic conditions, pain, or complex health needs, a credible exercise environment needs more than good intentions. It needs qualified staff, screening, progression, emergency readiness, and standards that healthcare providers can trust. MFA facility certification helps medical fitness centers demonstrate their commitment to quality, safety, and clinical credibility. Learn more about becoming a trusted MFA certified facility on the MFA website at medicalfitness.org. That's medicalfitness.org.